So, as you know me, I'm a pathophysiology guy, so I'm very, very big on pathophysiology. So I like to focus on it because if you understand the pathophysiology, the rest of the information is coming from that. So your heart, um, I draw the shape of the heart. I'm not good. So so you have your heart like that. Doesn't look like that. And then it's divided into four chambers. You have the right atrium, right ventricle, left atrium, left ventricle. You have your lung sitting here like that. And usually this is what happens. Blood from your head and your upper extremities will come into this vein, from this vein, which is what we call superior vena cava. All it means is from the top. Superior vena cava is a vein, big vein, draining the blood into the right atrium. From your lower extremities, your abdomen, the liver, the kidney, all the blood goes through the inferior vena cava. It's below, so it's inferior vein of big vein, basically. All these two big vessels, blood, the blood is returning has no oxygen in it. So it's called deoxygenated blood. So this is also negative oxygen. When you get to the right atrium, this deoxygenated blood is pumped through tricuspid valve in one direction into the right ventricle. Then the ventricle will pump this blood back to the lung. So that's the lung sitting here like that. So they pump it into the lung. So the blood go back into the lung through the pulmonary artery. Then from the lung, oxygen is added. So I will pick this red oxygen added to the blood, and it return back through the pulmonary vein. This is the pulmonary vein to the left atrium. So this has oxygen. From the left atrium, it goes to the left ventricle, and the ventricle pump it through the aorta, which supply the rest of your body. And it branches to different portions of the body. It goes so many places. So this is the aorta. And this blood has oxygen in it. So this blood has oxygen in it and supply the rest of the body. So this is the normal function of the heart. It pumps the blood out, it receives it. It pumps out, it receives it. It pumps out, it receives it. Sometimes things doesn't work the way we expect it to work. So you can have a case where the blood gets to the right atrium and it doesn't pump into the lungs anymore. And it stays mostly on the right side of the heart. And that is where you have right heart failure. Or the blood gets to the left ventricle and it can pump it out. So it stays on the left side and you have left heart failure. This is the easy way to remember it. Blood stay on the left side, it's not going out, coming out of the heart, and then become left-sided heart failure. If you stay on the right side too much, it become right heart failure. So what do we have? Usually, your body want to pump the blood out. So to the aorta, into the rest of the body. If he cannot do that, what do you have? You have less blood going into your body system. and therefore your body will not be happy. It will tell the heart to pump fast, so your heart rate go up. And since there is less blood going to the rest of the body, your pulses will decrease. And what happened to your extremities? Well, if there's less pulse going there, the extremities, less blood going there, the extremities will be cold. And since less blood is going out of your system, well, your blood pressure will be very low because your heart is trying to pump so fast, it's pumping a little bit of blood. If less blood coming out, the kidney will be mad. When you see less blood, your urine output will go down. So this is what happens when you have heart failure. All this, you see, is a SATA question. I can make this SATA. Somebody with a heart failure. You remember, I do not say whether the patient has a right or left. I just say heart failure. This is what happened. Less blood, increased heart rate, their pulses go up. They get cold because the rest of the body is not getting blood. The blood pressure goes down and the urine output decreases. When we're talking about the right heart failure, so now this is what you have. You have the right side getting bigger because blood is staying there. So this is the right atrium. This is the right ventricle. This is the left atrium, left ventricle. So you have oxygenated blood sitting here. It's sitting here. They're not going anywhere. They cannot go into the lung because this side is failing. It's failing. It's not doing its job. It cannot pump. So it get dilated. It got dilated. So they do, you will see something we call cardiomyopathy. That means it's a fancy name. So the cardio, that's the heart. Myopathy is a muscle. So dilated cardiomyopathy. That means the heart is dilated, mostly on the right side. So that's the first symptoms you see. So I told you that you have two big veins bringing blood to the right side, the superior vena cava and the inferior vena cava. Well, if this blood is not coming to the heart, well, it will back up. So all the blood in the left ventricle going to the right ventricle going to the right atrium, and it back up from where it's coming from. So it's like a traffic. The superior vena cava cannot give the blood back to the right atrium, the inferior vena cava. So let's take the superior vena cava, which is taking blood from the upper extremities. If you cannot do that, well, then blood in the superior vena cava will be high. And how do we see it? There's something we call JVD, jugular vein distension. In your neck, the vein in your neck become distended because there's too much blood for them and staying there. It can go to the superior vena cava to drain into the heart. So we call it JVD, which in the test, it can give you something we call CVP, central venous pressure. That means the pressure in the vein is too high. Usually the normal is 2 to 8. So you see increased CVP. So it will be greater than 8. Increased CVP is the same thing as increased JVD, which is the same as high level of blood in the superior vena cava. And so that's what you see. When do you see a patient JVD, they can ask you, which position would you be able to see? If you lay them flat, you won't be able to see anything. They have to be 45 degrees. So keep their head at 45 degrees and you'll be able to see their JVD. So when you examine the patient to see if they have right heart failure, keep them 45 degrees, you see fluid overloaded and they have JVD. Okay, because the blood is mostly in the right side and is coming, now is going backwards into the system, nothing going to the lung. These people have no lung symptoms. So be careful in the question. Right-sided heart failure, purely right-sided heart failure, there's no lung symptoms. Because all the blood is back up into the system, well, the blood in your leg, which will go into the inferior vena cava, cannot go. So your leg swells up. So you have edema in your leg. In your face, you get periorbital edema, especially in kids. Because all the fluid is building up in your system, what do you think? You're retaining fluid. You can't push it out, anything like that. Well, you gain weight gain. And remember, the liver and the spleen send all their blood to the inferior vena cava. Well, if blood is backing up in the inferior vena cava, the spleen and the kidney, the spleen and the liver, okay, will become bigger. And this is what we call splenomegaly. That means big spleen, and then hepatomegaly, enlarged liver. So the patient will have a spleen that is enlarged, and the liver that is enlarged. When the liver is congested, check my cirrhosis lecture, you can see a patient will develop ascites, which is the same as edema inside your abdomen. So these are the symptoms you see for patients who have right-sided heart failure. You can see how you can just, using the pathophysiology, you can be able to find out all the symptoms the patient is going to have. The best way for you to remember to answer question on right heart-sided failure is just use this definition. It's a systemic vascular congestion. So CVC, systemic vascular congestion, which is almost like superior vena cava, is the same. Systemic vascular congestion is the same as right-sided failure. And so that's why the patient, all the things they have is systemic: edema of the leg, face, weight gain, JVD, and a CVP greater than 8. So that's what you see on the right-sided heart failure. If you come to the left, the same thing. Blood in the lung, which has oxygen, going to the left side, left atrium and left ventricle. But it cannot do anything. It cannot pump. So it's dilated. So the heart is dilated. They too, they have like cardiomyopathy. It cannot push the blood the way it want to push it. Okay. So what happened? Blood will back up and go back to the lung. So, well, you go back to where it came from. He has to go back to the lung. So all the symptoms they're going to have is the lung symptoms. So I call the left heart failure as pulmonary congestion. So all your answer choice has to be pulmonary congestion. And what does that mean? Well, a patient will have dyspnea. It's a fancy word. All it means is difficulty breathing. So they will have dyspnea, difficulty breathing. They will have tachypnea, so they breathe very fast. And then another fancy name, orthopnea. Orthopnea. All it means is when you put them in supine position, they have shortness of breath. They don't want to lay flat. Patient doesn't want to lay flat. Then there's something we call PND, paroxysmal nocturnal dyspnea. So they'll be sleeping and all of a sudden they wake up and they have shortness of breath. You see, all this is lung symptoms. We don't talk about any systemic, is pulmonary congestion. So they have dyspnea, difficulty breathing, and tachypnea, breathing fast, autopnea, they cannot lay flat, and PND, paroxysmal nocturnal dyspnea. They are asleep and they wake up and they have shortness of breath. One key thing they like to ask is pulmonary edema. Remember, patient is drowning. Now he's drowning in fluid because of all the fluid back up in the lung, and they have pulmonary edema. In your test, they won't tell you it's a pulmonary edema. There's some few buzzwords you should know. They'll tell you patient has pink or blood stained, fruity sputum. I know there's a bunch of them. So they can say pink, blood, tinged, Tingled. Fruity sputum. This is not pneumonia. Every time you see think, bloody, no, think, blood tinged, fruity sputum, or pink fruity sputum is not pneumonia. That is pulmonary edema. Pulmonary edema is deadly. Patient is drowning in fluid. Basically, there's too much pressure in the lung that the vessels, the vessels are rupturing. The blood vessels rupturing and blood is going to the lung. So that when they have sputum come out, there's blood in it. So that is pulmonary edema. That is a priority. And as you can see, this is a B-sharp information. If you give you somebody with a heart failure, with a blood thing, sputum, fruity sputum, that means patient has pulmonary edema. That's a left-sided heart failure. It's a priority patient. Okay, then they will have, if there's fluid in your lung, what do you think? They'll get crackles. Okay, they will get crackles. So these are classic symptoms of the heart failure. So like you said, right side heart failure is a systemic vascular congestion. Left heart failure is what? Pulmonary congestion. So you're looking for answer choice of pulmonary congestion. If they tell you patient has chronic CHF or chronic heart failure, or they trying to tell you patient has left heart failure plus right heart failure. So pay attention. In the question, if they want to tell you it's a right heart failure, they will say it. If they want to tell you it's a left heart failure, they will say it. But if they don't say anything, they give you chronic heart failure, look for answer for both left heart failure and right heart failure. So all the two symptoms will be there. Okay, so we have a problem. How do we fix it? How do we fix it? I think I've already talked about this. How do we fix it? Well, patient has too much fluid. And we got to get rid of the fluid. So number one, they get furosemide. That's laces. So diuretics or bumetanide, or the or the diuretic with the mind. So laces. Remember, laces act for 6 hours. So it lasts for 6 hours. So you get rid of the fluid, okay? Then you have the heart to pump. So they can get like ionotropes, like dopamine or dibutamine. This can pump the heart. The other medication they like to use is Digoxin, Digitalis. Then you can prevent the heart from getting dilated and become cardiomyopathy. The medication they use is ACE inhibitor or ARB. Sometimes you can dilate, prevent blood from going to the heart, and so use vasodilators. You see what I'm doing? Just by pathophysiology, I'm just telling you what you usually you do to treat these medication, these problem. And so we'll go through this big pharmacology. And then we have a diuretic. We can have another diuretic, potassium sparing, that means spironolactone or hydrochlorothiazide. They can give you any of them. So we said, get rid of the fluid, help the heart to pump, digoxin to do that, help the heart to remodel, ACE inhibitor, and then vasodilator. So we'll take each one of them and quickly. So furosemide. This is laces or bumetanide. They are diuretic. So you pee out the urine. So they decrease fluid in the system. So the urine output is going to increase to get rid of the fluid. This is a sulfur drug. So all diuretic is a sulfur drug. Just know that all diuretic is a sulfur drug. So you teach the patient to avoid sunlight, wear clothes to cover their skin, wear sunscreen. So prevent sensitivity. So sunscreen, wear long clothes when you go out, wear a hat when you're going out on a patient taking laces. So as you can see, I'm using education to help with that. It also it can affect your hearing, tendinitis, so orthotosity. So tendinitis or orthotosity. Whenever you have injury to anything that affects your ear, is permanent. So you got to prevent that. And it happens when you're giving Lasix IV. So if you're giving Lasix IV too fast, so you just slow down. The other side effect is because they're losing a lot of water, what do you think happens? They become orthostatic hypotension. So you tell them to get out from bed slowly. Don't get out fast. The other side effect is decrease your potassium. So hypokalemia. So patient taking laces, what education do you tell them? Where eat some banana, get some banana so that you won't lose your potassium. So those are the key side effects. Hypokalemia, tell them to eat some banana. Orthostatic hypotension, get out from bed slowly. Tendinitis. So when you're giving it IV, give it slowly. It's a sulfur drug. And what you do, they should wear sunscreen, cover their skin, wear a hat when they're going out, and going out, basically. There's one, and then the number one side effect is hypokalemia. It's B sharp. You know, hypokalemia has cardiotoxicity, cardiorhythmia. So anybody on laces or furosemide, you should check their potassium. One thing I need to tell you is sulfur drug, the sensitivity is not that bad, but they can develop something we call Stevens-Jones syndrome. They can say purple rash on the skin. That is not just photosensitivity. That's Stevens-Jones. That's a priority patient you see on any patient on sulfur drug. So this is the side effect of laces and some of the teaching you tell them. They know that everybody knows laces, so know this one. Bumetanide is bumetanide. All you need to know is their last name, furosemide and bumetanide. So that is the treat laces. The other medication we talk about is ACE inhibitor and ARB. This is very interesting. So pay attention a little bit. In our body, we have something we call angiotensinogen. And this angiotensinogen is made in the liver, and it go to the kidney and is converted into angiotensin 1 by renin in the kidney. Then angiotensin 1 go to the lung and get converted into angiotensin 2. And this angiotensin 2 go to your body, the kidney, to reabsorb sodium. So it causes aldosterone. And it's the aldosterone that increases sodium and decreases potassium. The angiotensin 2 is also a vasoconstrictor, which causes hypertension. You see what is happening? So you have this angiotensinogen going all the way to angiotensin 2. So I will draw angiotensin 1 being converted into angiotensin 2. And this angiotensin 2 will lead to aldosterone. That will lead to high sodium and low potassium to increase your blood pressure. This is what happened. This is the renin-angiotensin system. I don't want to mention it, but that's what it is. So when you take a ACE inhibitor, it blocks this. ACE inhibitor basically block angiotensin 2 from being converted, and angiotensin 1 from being converted into angiotensin 2. So ACE block here, sorry. We block angiotensin 1 being converted into angiotensin 2, such that angiotensin 2 cannot make aldosterone. And this is what decreases aldosterone production. Therefore, you cannot lower potassium, so your potassium goes up. And you rather decrease sodium. And this is what decreases your blood pressure. Once again, angiotensin 1 is converted to angiotensin 2. That's ACE inhibitor block this and prevent converting angiotensin 2, which angiotensin 2 will lead to aldosterone, but there's no more aldosterone. And so there's no need for you're not going to get rid of your potassium and increase your sodium. You end up increasing your potassium and decreasing your sodium. The other thing that happens is there's something called bradykinin. It's converted into inactive form. This is the histamine. If angiotensin 2 block this, you have higher level of bradykinin. Bradykinin causes cough and angioedema. So this is what causes why ACE inhibitor cause cough and angioedema. These are the side effects of ACE inhibitor. Increase your potassium, lower your sodium, so lower your blood pressure, so you become, you have orthostatic hypotension, you see, and then you have cough. These two symptoms are not common. They are not something you ignore. A patient that is coughing is non-productive cough. They cough, but there's no productive. It's nagging cough. And then angioedema. These two, you need to call HCP. It's a priority patient you see. Any patient on ACE inhibitor and coughing or have angioedema, it's a priority patient. They have airway issue. It's a B-sharp issue. You need to call the doctor right away. They need to stop the medication and go to the emergency room, especially angioedema. The cough, they need to go and see their doctor, and the doctor will change the medication. ACE inhibitor is also a teratogenic. That means if you're pregnant, you shouldn't take it. It also increases your creatinine level a little bit. So this is a setup question. Side effect. ACE causes hyperkalemia, hyponatremia, that decreases your blood pressure. It causes cough, dangerous. Angioedema, dangerous. Teratogenic, dangerous for a pregnant lady. So if a patient is taking this for heart failure and is coughing and having angioedema, well, we can give them ARB. And because ARB doesn't do what the ARB does is, let me draw this again. You have angiotensin 1 going to angiotensin 2 and angiotensin 2 making aldosterone. ARB doesn't block angiotensin 1 going to angiotensin 2. All it does is it come here and block aldosterone, angiotensin 2. Sorry, no, it block angiotensin 2 from leading to aldosterone. So it doesn't block 1 going to 2. Since it doesn't block 1 going to 2, bradykinin can become inactive form. Therefore, there is no cough. They have no cough. They have no angioedema. So if somebody is taking ACE inhibitor and coughing, give them ARB. If they develop angioedema, give them ARB. Angioedema is dangerous, so it's airway, so it's bad. But it still will cause, because it's decreasing aldosterone production, the potassium is going to go high, the sodium is going to get low. So they have the same thing, except they do not cause cough and angioedema because you block angiotensin 2 from going to aldosterone. So that's the day 2, they are teratogenic. So pregnant lady should avoid them. The last medication we're going to talk about is digoxin. And this is a very testable question. Digoxin for heart failure is basically, it helps with the pump. It has 3 functions. It decreases time. So we call it is a chronotropic. So it decreases the heart rate, slow down the heart. Is ionotropic. It helps with contraction. So it increases your cardiac output so your heart can pump, and it speed up the heart. It's called chromotropic. So it speed it up with its chromo, it increase the contraction, ionotropic, and it slow down the time with its chronotropic. It has very narrow therapeutic level, 0.9, 0.5 to 2. So it's a very dangerous medication, very narrow. And then it causes bradycardia because you lower the rate. Because of that, there's a bunch of teaching you need to know. It causes bradycardia and it can cause a heart block, slow down the heart. So patients need to take their pause, apical pause, 1 full minute. 1 full minute to when they take digoxin. If you take digoxin, 1 full minute. And if you are an adult, if your heart rate is less than 60, stop it. Don't take it. If it's a child, less than 70, don't take it. If it's a neonate, less than 90, don't take it. Check the pulse for 1 full minute. Heart rate less than 70 for adults, don't take it. 70 for children, 90 for neonate. The side effect, the way I remember it is you start from your head to toe. It affects everything. So your head, so neuro. The digoxin causes confusion and some lethargy. From your head, you come down to your eyes. It's a common side effect. They will see yellow and green or blurred vision. Tell them to call the doctor, not their ophthalmologist. You don't need to call your ophthalmologist for this. Call your doctor when you see yellow, green vision or scotomas. Then from their eyes, your mouth is there. They have GI symptoms. This is the first symptoms they will show. So they will have nausea, vomit, anorexia, okay, and abdominal pain. GI symptoms is number 1. So anybody taking digoxin who is of nausea, vomiting, anorexia, and then abdominal pain, they need to call the doctor right away. It's a sign of toxicity. So they need to call the doctor right away. GI symptoms, number 1, earlier signs they show, they need to call doctor right away. So if they have nausea, vomit, abdominal pain, need to call doctor right away. Because of this, for children, okay, for children, usually we give this as oral medication and you put it at the back of their mouth or on the side. Don't mix it with anything for children. Just give it to them right away. Okay? And because of the early signs being GI symptoms, if the kid vomit or they don't want to take it and they have nausea, don't force them. Call the doctor. It may mean they have toxicity. So a kid getting digoxin who has nausea, vomit, or abdominal pain is a sign of toxicity. Don't force them. If they miss 2 doses, call the doctor. If they vomit, don't give them additional dose. If they vomit, don't give them additional dose. If they miss 1 or 2 doses, call the doctor. It's very important because GI symptoms is number 1 early signs of that. Okay? And then watch their mouth after they take the medication. So we talk about GI. You also have to worry about kidney. Digoxin is broken down by the kidney. So if somebody's kidney function is abnormal, well, you should stop it. Otherwise, they will have toxicity. Okay. Now, there's certain things digoxin does. It makes your potassium go down. So hypokalemia. Because of that, you should avoid hypokalemia. That doesn't mean you should take potassium. It means keep the patient potassium normal. So if they ask you a question, somebody on digoxin, what should you do? Make sure avoid hypokalemia. Avoid it. Don't make them hyperkalemia. Make their potassium normal. So ensure that they are potassium normal. You should also avoid hypomagnesium. So don't make sure their magnesium is not too low. Make sure their potassium is too low. And then avoid hypercalcemia. Make sure their calcium is not too high. Okay, make sure when you're taking digoxin, potassium is not too low, magnesium is not too low, and calcium is too high. So you avoid those things. Don't give them too much potassium. That potassium is too high. Make sure potassium is normal. Because of this, avoid calcium channel blocker, because calcium channel blockers will make your what? Calcium high. They should also avoid this. There's a medication that will decrease your potassium. Licoric rice, licorice, LOCO, licorice. This decreases your potassium, and that will worsen digoxin. And finally, is to avoid ephedrine. This is usually found in cough mixtures, medications. It will increase your blood pressure and it causes arrhythmia. Remember, digoxin, the major problem is bradycardia, cardiac arrhythmia, and heart block. So if you take ephedrine, you're going to make somebody digoxin toxicity high. So digoxin, things you should avoid hypokalemia, avoid hypomagnesium, avoid high calcium hyperkalemia, avoid calcium channel blocker, avoid ephedrine, and avoid licorice. Now, let's teach a patient with a heart failure. Okay, heart failure. Well, they have too much fluid. So what do you tell them? Avoid or limit sodium. So they should limit their sodium to 2 grams a day. And then they should check their weight. If they weigh more than 3 pounds in 2 days or greater than 5 pounds in 1 week, they should call the doctor. They should weigh themselves every day at the same time, using the same scale, wearing the same clothes. Weighing yourself same time, same scale, same time, wearing the same clothes. You should also avoid frozen food. Frozen food has a lot of sodium in it, so they should avoid it. The good thing is they go for cardiac rehab so that they can improve their heart function. If they're taking diuretic, that will decrease their potassium, like laces, then they should try to increase their potassium, like banana. If they're taking spironolactone, that will be potassium sparing, but they shouldn't take any potassium. And then they should take rest period because they have heart failure. So when they're walking around, they should take a break and then allow some rest. With rehabilitation, that may improve. So these are the teaching you tell a patient what they need to do and education. So make sure sodium is less than 2 grams. If they're weighing 3 pounds in 2 days or 5 pounds in a week, that's heart failure. They should let their doctor know. And weigh themselves the same time, same scale, same clothes every day so that they can know if they're retaining fluid. They should be compliant with their medication and avoid potassium if they're taking spironolactone and take potassium if you're taking laces. Cardiac rehabilitation to improve their function. There's one thing that they can ask you is this lab value, BMP. And if they give you a BMP greater than 100, that's heart failure. This is secreted by the ventricle and it shows dilation how much fluid is in the ventricle. So BMP is a lab test for a patient with heart failure. So this is everything about heart failure.